Good morning, good afternoon, good evening. It is a real pleasure and honor to introduce Professor Diana Esther Rossi from Rome as a first speaker of the new series of cytopathology-related talks. Today, Diana will talk about difficult thyroid lesions. She is a professor of anatomic pathology and histology at the Catholic University in Rome. She is the head of endocrine and cytology units at AgostinoGemelli Hospital. She is the chief editor for Europe at World Tumor Registry and associated editor for Cancer Cytopathology. In addition, she is president-elect of the Papanicolau Society of Cytopathology, and she is co-chair of the scientific committee of the European Federation of Cytological Societies. And last but not least, she is a chair of a webinar committee of International Academy of Cytology. Podium is yours, Diana.
Thank you so much. Thank you so much, Ivana. Thank you so much, everyone. And it's really my pleasure and my honor to start this new series of webinars as the chair with my co-chair, Professor Kholová. We are going to start this new 3 years about the webinars. And I'm going to open this with this topic, difficult thyroid diagnosis, lesion often missed on cytology. No conflict of interest for the Milan, the Bethesda, and the different WHO histology. So we have to think about what can be diagnosed on thyroid FNA. Something absolutely possible, something tricky, something very difficult, and something impossible to be diagnosed. And we are going through all of them with also some examples. For the absolutely possible, the elementary Watson, you will see some references to movies because I'm really keen on movies. We have benign lesions like goiter or Hashimoto thyroiditis, which in the classical example are pretty easy, as well as when we follow the criteria for AUS and follicular neoplasm, it's not so difficult, or the identification of a population of oncocytic cells more than 75%, but also the criteria for papillary carcinoma, nuclear and papillary structures. And sometimes also metastatic lesions can be easy if we know the clinical history. For the benign follicular nodular disease, usually we have this solid cluster pattern defined, as you can see here, by this monolayer sheet of cells, loosely cohesive, small, dark follicular cells with watery of thick colloid. Usually we can recognize this very loosely cohesive cluster in which we have this poorly defined cytoplasm border. Small size looks like red blood cells, and also this very delicate, of course, cytoplasm. Also, another possibility is, of course, to combine flesh sheet with some balls of spheres, in which, however, in benign entities, we have the maintenance of polarity, as you can see here. Something more tricky, even in these easy cases, is the evidence of grave disease, in which we have this monolayer sheet of cells with abundant cytoplasm, and the famous flame cells, in which we have this marginal cytoplasmic back walls at the periphery. It's not uncommon to have some sort of anisonucleosis, some small prominent nucleoli, and also some sort of nuclear cleaving, which, however, should be evaluated in the context, of course, of the grave disease. It's not difficult, as mentioned, to recognize oncocytic cells with this granular and oncocytic appearance of the cytoplasm and this round oval nuclei. And also the typical features of PTC on the right, nuclear pseudoinclusions, grooves, and papillary structures. Something more tricky can be with oncocytic cells if we have some laminated concretion, which are frequently associated with oncocytic oncocytic lesions. We recently published a paper about that on Birkhoff Archives. And of course, they can be resemble samoma vadis, and we need to look for the nuclear features of PTC. But another difficult can be the evidence of and the lack of lymphoepithelial clusters in Hashimoto and in chronic thyroiditis. If you see only the oncocytic cells, then it's better to classify this lesion as AUS. Of course, metastasis in some cases is not so difficult because we know the clinical history, we have a good imaging, and so we can apply easily the different ancillary technique, especially immuno. It's extremely important, of course, the correlation with the clinical history. These are some examples from my cases. In the upper right, a melanoma. You will see another case in which it was not so easy, or a small cell lung cancer to the thyroid, or a renal carcinoma with this oncocytoid appearance. Let's move on the tricky on cytology introduced by Tutsi and Dustin Hoffman. Hyalinizing trabecular tumor, medullary thyroid carcinoma with the different phases. Papillary carcinoma subtypes, although it's not necessary, as reported by the Bethesda, to classify them. METs, if we don't know the clinical history. Lymphoma and non-epithelial lesions. And I would like to start with this case, a female, 29-year-old, 2.6 centimeter right lobe. Looking at the liquid-based cytology, you can see these isolated cells, mostly spindle elongated, with also this very minimal and also elongated oncocytoid appearance of the cytoplasm. Some sort of perinuclear halo and some irregular but very mild atypical nuclear features. And on the right, this small cluster with this granular oncocytoid appearance. Looking at the conventional slides, we have these spindle, elongated cells, one groups, some sort of nuclear cleaving resembling also nuclear pseudoonclusions, a sort of again of oncocytoid appearance. So, as marker on the Rank Express, we have several options. Suspicious for malignancy, positive for malignancy favoring a PTC, medullary thyroid carcinoma, of course, but also something more vague, follicular neoplasm, some spindle features, and few pleomorphic finding. On the LBC store material, we perform a cell block and immunostains, showing positivity for thyroglobulin and TTF1, so thyroid origin of this lesion. Negativity for HME1 and galectin-3, which is usually also, according to our study, positive in papillary carcinoma and its subtypes. Calcitonin and CA, so we excluded a medullary thyroid carcinoma, and CD34, so we excluded a solitary fibrous tumor. This is the cell block and the strong positivity for thyroglobulin and TTF1. So in this to be and not to be, how should we call this lesion? We decided for something which was well-differentiated thyroid proliferation with some spindle elongated features and few mild pleomorphic finding, putting in the comment that the differential diagnosis included follicular adenoma, hyalinizing trabecular tumor, mesenchymal lesion. This was a tier 3B according to the Italian classification, or follicular neoplasm according to the Bethesda. The patient underwent lobectomy, showing this solid alveolar trabecular pattern, some sort of metachromatic stromal component, mostly in the cytoplasm, and the nuclear features that we had in our case. So these groups, some nuclear pseudoonclusions. At this point, we perform also MIP1, which was positive. So the diagnosis is easy as hyalinizing trabecular tumor. Let's define how the Bethesda reported this. Usually we have these neoplastic cells which are radially oriented around this amyloid-like stromal component. Round, oval or spindle-shaped nuclei with nuclear grooves, nuclear pseudoonclusions, occasionally some vadis, some perinuclear halo, as in my case, and the lack of papillary structure, and positivity for thyroglobulin, TTF1, and MIP1 membranous positivity. Sometimes it's very tricky because it's a rare entity, and of course, the most important differential diagnoses are much more commoner. Papillary thyroid carcinoma, in which we do not have the metachromatic extracellular matrix. Usually, PTC have fewer nuclear grooves and pseudo-inclusions, but more papillary structures. Nuclear cleaving is also more pronounced, and of course, the typical immunostains. Medullary carcinoma has another important differential diagnosis. More pronounced spindle cells, eccentrically located nuclei, salt and pepper chromatin, and calcitonin staining. But sometimes it's very difficult to distinguish among extracellular matrix, colloid, and of course amyloid. And this is another example of a male homozygote, 51-year-old, 2 centimeter right lobe hypoechoic. Look here, you can see also this metachromatic stromal material, but looking at the cells, you can recognize these spindle elongated features with some sort of wavy nuclei. In this case, S100 and SOX10 is positive and negativity for TTF1 and the thyroglobulin. And in fact, this is a case of schwannoma, and this is a cellular schwannoma. So you can see how this metachromatic stromal component can be seen and can be tricky in different entities. We published a paper about the Hyalinizing trabecular tumor, and you can see 18 cases, the majority were in the indeterminate categories. Also, we compared with the other entities, PTC, MTC, and NIFT, and you can recognize how cytoplasmic yellow bodies, MIB1, are only seen in Hyalinizing trabecular tumor. But in 2019, really the change was this paper published by Professor Nikiforov. Gleason arrangement is a genomic hallmark for Hyalinizing trabecular tumor. 14 cases, mostly female, analyzed with next generation sequencing. And you can see that there was a fusion type, PAX8, GLIS3, PAX8, GLIS1 in all the cases, and only one PTC, excluding any aggressive PTC. When we have spindle elongated features, with or without, we see grooves and inclusion, we have many differential diagnoses, spans a wide gamut. Benign entities, renal thyroiditis, resembling a clinical anaplastic thyroid carcinoma, usually lack of epithelial cells, mostly inflammatory cells and lymphocytes. The effect of an FNA due, and in this case, we have fibroblastic and myfibroblastic cells. Follicular neoplasm with the spindle areas is not uncommon. Clear cell oxyphilic neoplasm, especially in my case, because of this small cluster of oncocytoid appearance. Hyalinizing trabecular tumor, solitary fibrous tumor, a smooth muscle tumor, but also some malignant entities, papillary thyroid carcinoma. We will see that we might have some spindle cells there too. Medullary thyroid carcinoma, fully differentiated anaplastic carcinoma, in which, however, we have to recognize more atypical features, and metastatic tumor. And this is an example of PTC with the spindle elements, which are especially seen in the tall cell subtype. Two other examples of spindle appearance, solitary fibrous tumor from mycelius on the left, and medullary thyroid carcinoma. You can see the differences in the solitary fibrous tumor. We have this elongated spindle nuclei with very granular and delicate chromatin and the lack of cytoplasm and some sort of minimal stromal component. On the right, we have a medullary thyroid carcinoma with spindle, but also some plasmacytoid, some epithelial cells with also binucleated cells, and this typical salt and pepper chromatin. But it's essential the support of immunostains, which is positive for calcitonin in, of course, MTC, negative in solitary fibrous tumor, as well as in both of them, we have negativity for thyroglobulin, and in solitary fibrous tumor, we have positivity for CD34, but not only. This is the histology of the case of solitary fibrous tumor, a cellular solitary fibrous tumor, and you can see the follicular structure and the positivity diffuse for CD34, but also the nuclear positivity for STAT6, which is highly specific. And also the different pattern of medullary thyroid carcinoma, more solid alveolar, more some sort of spindle and plasmacytoid, and a strong positivity for, of course, calcitonin. When we are in presence of nucleoside occlusions, we have to think about several entities. Firstly, of course, PTC and its subtypes, the most common, but they can be seen also in medullary thyroid carcinoma. We need to remember that in anaplastic carcinoma focally, but also in hyalinizing trabecular tumor, in paraganglioma, we will see an Langerhans histiocytosis. Also, when we think about the papillary structures, they are frequently and usually associated with PTC, but can be seen also in medullary thyroid carcinoma, in metastatic lesion, and also pseudopapillary hyperplasia, in which we have this hyperplastic pattern with a small and dark nuclei. And also, it is not uncommon to have some papillary structures associated with oncocytic cells. We have to look for the nuclear features, of course, of papillary carcinoma. This case, specifically from the Bethesda, was a oncocytic papillary carcinoma. Why? Because we have to look for the nuclear features, because, as you know, we have the oncocytic subtype, in which we have the papillary carcinoma, in which we have the oncocytic, oncocytoid appearance of the cytoplasm, but also the nuclear features of PTC. Let's move on another entity with Rango and the chameleons to introduce medullary thyroid carcinoma, the great mimic curve, usually cellular smear, mixed or non-cohesive, crowded, syncytial-like aggregates with different morphology, polygonal, spindle, plasmacytoid, round, usually with this round, oval and elongated nuclei, some sort of mild and moderate pleomorphic finding, some red-purple granules which can be useful for the diagnosis in some cases. In a minority of cases, we have cytoplasmic backballs, melanin pigment, and also some, as mentioned, nucleoside inclusions. In 1/3 or half of the cases, we have this amyloid, which, however, is indistinguishable from amyloid goiter and can be seen also in few cases of PTC. So it's critical, the support of immunostains showing positivity for calcitonin and, of course, CA in the mononuclear HAM, and also negativity for thyroglobulin. The tricky evidence is done by the fact that we might have different growth patterns, as you can see here, including, for instance, clear cell, encapsulated, follicular, oncocytic, papillary, paraganglioma-like, small cell, spindle, and so on. Here you can see an example of plasmacytoid and epithelioid features and small clusters of amyloid. And the difficulties is based on the daily practice in which we have different phases on This is from Mycevius again, on the left, spindle, epithelioid, plasmacytoid, but also we might have some sort of follicular pattern or, as seen here, more plasmacytoid, resembling some with this delicate cytoplasm, some oncocytic cells. As mentioned, in fact, in the Bethesda, medullary can be very tricky to be distinguished from oncocytic follicular neoplasm. The only morphological difference can be the granules, which are usually red and blue in the MTC and blue in the, of course, oncocytic neoplasm, but it's really difficult to recognize them. Or medullary thyroid carcinoma versus poorly differentiated carcinoma, especially in this cohesive and diffuse pattern. Also because in both of them, we might have some sort of cytoplasmic backballs. In other cases, it's difficult also to distinguish the medullary thyroid carcinoma, the Jan type cells, from anaplastic thyroid carcinoma on the left. It's only based on the difference in the immunostains, so morphology sometimes it's really enabled to make this diagnosis. On the right, you can see a case from mine, a diffuse population of cells having this elongated spindle and sort of plasmacytoid appearance. This is the conventional slides in which we maintain the same pattern. This lesion was negative for keratin, was negative for thyroglobulin and TTF1, so I decided for a possible non-primary thyroid lesions, but this at the end, this is a CD31, this was an angiosarcoma of the thyroid. For showing these similarities that we might have among medullary, anaplastic, and of course some other rare entity like this. In this picture, I would like to show you the waxy appearance and the line evidence of amyloid, which in some cases is difficult to distinguish from colloid. As mentioned before, positivity for TTF1, for calcitonin, for chromogranin, and negativity for, of course, thyroglobulin. The differences in the cytological pattern are also reflected in the broad range of cells appearance on histology, as reported in this picture from Nikiforos' book. This is another case, a female, 65-year-old, 6 centimeter hypoechoic left lobe. Again, looking at this slide, so you can see this cellular smear, in which again we have a sort of plasmacytoid appearance, regular nuclei centrically located, very delicate cytoplasm. We perform of course, different immunostains, because in this plasmacytoid pattern, it can be an hyperplastic nodule with oncocytic features in Hashimoto thyroiditis, or an oncocytic neoplasm, or a medullary thyroid carcinoma. On LBC, we perform thyroglobulin, calcitonin, which were all negative. So we started to think about the real plasmacytoid pattern, the one of plasma cells. And in fact, they were positive for MAM1, as you can see. The patient underwent histology, and this is the plasmacytoma primary on the thyroid gland. Let's move on another case. This is the story of another patient with the history of a long history of Hashimoto thyroiditis, 7.5 centimeter enlarging right nodule. So easily at the beginning, we started to think about an hyperplastic nodule in thyroiditis. But you know, this was a very sparsely cellular smear in which I didn't recognize oncocytic or cellular or follicular cells. Only these isolated cells, large, with scant cytoplasm, few of them, a prominent nuclei, some others with a lack of cytoplasm, some sort of lymphoglandular body, few cells resembling very typical lymphocytes, but the difference was that in this case I didn't have enough material, so I decided for immuno, for flow cytometry, so I decided according to the Bethesda to sign out as AUS, emphasizing that I have this population of typical lymphocytes. The patient underwent also in this case total thyroidectomy, showing a molten lymphoma with areas of diffuse large B cell. This is for introducing the lymphoma, 90-80% non-Hodgkin B cell lymphoma. Two-thirds preceded by Hashimoto thyroiditis. We might have three different patterns on cytology: small and large lymphocytes, monotonous large lymphocytes, monotonous small lymphocytes. Usually we have a macrocellular smear composed of non-cohesive cells with round, oval features, some sort of lymphoglandular body in the background. And we might have two different types: the diffuse large B cell, in which we have really large lymphocytic cells, 3-5 times the normal and small lymphocytes, and in which usually we have some moderate cytoplasm, or the, of course, multiple lymphoma, in which we have this uniform intermediate size lymphocytes with a small nuclei and granular chromatin. It's crucial, however, the support of immunostains and flow cytometry, and really a tough diagnosis on cytology. Also, this is for introducing another very rare entity, the Langerhans histiocytosis, in which usually we have some isolated. The picture on the right is from the Bethesda. This is a picture of our case, in which you can see the difficulty in recognize these cells, usually large mono or multinucleated Langerhans cells with this abundant pale cytoplasm, but also some nuclear folded, some nuclear grooves, or some nuclear pseudo-inclusion. And in fact, the most important differential diagnoses include papillary carcinoma, medullary carcinoma, poorly differentiated, or follicular neoplasm. The evidence usually is the abundant eosinophilic component, which can be in favor of this diagnosis. Negativity for thyroglobulin and TTF1, positivity for Langerhans and CD1A. But let's move on the difficult diagnosis, and I would like to introduce them with this picture of the Cohen brother, because they are really tough directors. For poorly differentiated high-grade, medullary again in some way, anaplastic, lymphoma can be tricky or very difficult, paraganglioma, non-epithelial lesions, but also some rare tumor, including the salivary-like lesions and the intrathyroid thymic lesions. I would like to start with the high grade because the 2022 WHO identified two groups of high grade non-anaplastic follicular cell-derived carcinoma with an intermediate prognosis between well-differentiated and anaplastic carcinoma. The poorly differentiated carcinoma maintaining the criteria in the Turing criteria that we know, but also this new entity, differentiated high grade, which are invasive high grade follicular cell-derived neoplasm, which still maintain some differentiated features, including, for instance, nuclear features and papillary structures of PTC, or the follicular growth pattern or follicular carcinoma, sorry. Bethesda introduced them in a new chapter, including poorly differentiated and differentiated high grade, based on the fact that non-anaplastic carcinoma with necrotic component and mitotic figures that should be more or equal to 5 per 2 millimeters square have an aggressive behavior intermediate between well-differentiated and anaplastic carcinoma. Of course, the Bethesda defined the criteria for the differentiated high grade. Usually we have the classic nuclear features and structure of PTC, or some of the features of follicular carcinoma in a minority of cases, or oncocytic features. But comparing with the classic, of course, the PTC and the classic carcinoma, we have more atypical cellular feature, nuclear enlargement, more pleomorphic finding, necrotic and or mitotic component. Generally speaking, we have to say that the differential diagnosis with well-differentiated carcinoma can be very challenging and difficult if we do not recognize necrotic component and mitotic figure. And of course, we might have different options, papillary structures or discohesive and small cluster of cells. It's important to recognize necrotic component on the slides on cell block, mitotic figures, but here you can see the positivity for thyroglobulin showing the differentiation. We recently published a multi-institutional study of 40 cases. These are the picture from the cases. You can see here some necrotic component. The majority were PTC and its subtypes in this group. For the poorly differentiated carcinoma, basically no significant changes. So they maintained insular, solid, trabecular, or microfollicular and follicular pattern. In fact, frequently they are diagnosed as follicular neoplasm. Uniform population of malignant cells in which we have an increased nuclear cytoplasm ratio, but unfortunately a very variable nuclear atypia, which is the reason for the difficulty with this cytological diagnosis. According to the endocrine pathologist, this is an impossible diagnosis on cytology. Necrotic component and mitotic figures if we are lucky. And you can see three-dimensional cluster, insular appearance on the right, on the left, but also the problem is on the left, in which we might have mild atypia resembling again a follicular neoplasm, or in some lucky cases we might have the anisonucleosis as in the right, of course, bottom. Let's move on another case. 40 female, 49-year-old, hypoechoic, 3.8 centimeter left thyroid lobe. Looking at the slides, we have a cellular smear with also this discohesive population of cells, resembling in some point some sort of pseudo loosely cohesive sheets. You can see this poorly defined, but also some large granular cytoplasm, eccentrically located nuclei, in some of them some sort of steeple chromatin and chromatin cleaving, some isolated, elongated, naked nuclei, and some transgressing vessels. This is for introducing the intrathyroid ganglioma, which was published as a multi-institutional series, including this case. The definition, of course, and the criteria are well explained by the Bethesda. Usually we have a cellular smear, cluster of microfollicular structures, a few naked nuclei, granular cytoplasm, and also these poorly defined cell borders with some nuclear pseudo-inclusion and steeple chromatin. Positivity for chromogranin, synaptophysin, Has100 in the sustentacular cells, and negativity for cytokeratin, thyroglobulin, and calcitonin. And you can see here the example, and also this spindle appearance of the cells. Several differential diagnoses also in this case, and it's tricky for this reason. Follicular neoplasm, oncocytic neoplasm due to the granular oncocytoid cytoplasm, or AUS, papillary thyroid carcinoma, medullary thyroid carcinoma, Hyalinizing trabecular tumor, but also some intrathyroid parathyroid that we will see, or melanoma and metastatic NET if we have some atypical features. In these slides from the paper, you can see the immunohistochemistry in the differential diagnosis and how paraganglioma is defined by positivity for chromogranin and synaptophysin, which is, however, positive in also medullary thyroid carcinoma, but there we have also calcitonin and CA, and negative in the other, of course, entities. This is the example of the histological paraganglioma in my case, and the strong positivity for chromogranin. Another difficult lesion that might happen, of course, is the mucoepidermoid carcinoma. Basically, it is identical to the MIAC in the salivary gland. So we have a combination of mucus-producing cells and the squamous cells in, of course, small in clusters, and the mucinous component. Positivity for keratin, P63, P40, negativity for the neuroendocrine markers, thyroglobulin and TTF1 can be seen in some of the cases. Another difficult entity is the sclerosing mucoepidermoid carcinoma with eosinophilia, which is in the uncertain histogenesis from the WHO, the last edition. Mostly it is associated with Hashimoto thyroiditis, but we have this diffuse and uniform population of intermediate cells with this squamous appearance. But looking at the cells, you can see this very regular, round, medium-sized nuclei with some prominent, eccentrically located nuclei. Positivity for thyroglobulin, negativity for TTF1, negativity for thyroglobulin. Of course, it is not uncommon, although it is rare, to have a secondary carcinoma in the, of course, thyroid with the same criteria that we had on the salivary gland, mostly follicular papillary cluster rather than isolated cells. And look at the cells. You see eccentrically located nuclei with a very large cytoplasmic unique backbone. Positivity for S100 for mammaglobulin and the typical ETV6 and TRT3. It is also possible to have an intrathyroid thymic lesions. Of course, we can start it with the thymoma, and we have the two different types of thymoma. The type A, in which we have a variable amount of lymphocytes and mostly epithelial cells with a spindle, elongated nuclei, and granular chromatin in this fuse for nuclei. But also type B, in which there is a prevalence of lymphocytic component with some polygonal cells. This can be tricky for Hashimoto thyroiditis, but we do not recognize the typical oncocytic cells. And immune is essential. Keratin positive, CD5 positive, TTF1, and thyroglobulin negative. We have to consider also the spindle epithelium intrathyroid thymic lesions. Usually this is a very tricky biphasic lesion, squamous and glandular, perivascular appearance, large cluster of cells, again, very tricky, but also likely very rare. Keratin positive, vimentin positive, negativity for TTF1, thyroglobulin, and calcitonin, because it can be mistaken for medullary thyroid carcinoma. And last, but not least, for this group, we might have an intrathyroid thymic carcinoma, the old castle definition, in which we have this dirty background and some lymphocytes, but also some small cluster of poorly differentiated cells with variable nuclear size. Usually negativity for TTF1, thyroglobulin, positivity for cytokeratin 5, CD5, P63, CD117, CA, and P53. This is for introducing another case. This was an old woman, 78, with a rapidly growing right nodule. We have the liquid-based cytology, in which has this case didn't read the book. We have very few clusters, in which, however, you can recognize this significant and increased nucleocytoplasm ratio, atypical pleomorphic nuclei, some sort of necrotic component. And then they perform another pass for the team prep, which was sent for cell block, in which you can see the necrotic component, and also there's atypical irregular cells with also prominent nuclei and the binucleated cells. A few weeks ago, we have this other case, male, 75-year-old, 2.5 centimeter left thyroid lobe. Necrotic component, some very isolated cells. You can recognize some also very nice follicular cells here, but also here you can see multinucleated giant typical cells, very regular, very atypical, binucleated, some sort of debris and necrotic component. We perform the immunostains showing positivity for keratin, negativity for thyroglobulin, and this is the cell block from this case. This is for introducing the anaplastic thyroid carcinoma. Variable cellularity, isolated cells or group of cells ranging from small to giant, which can be epithelioid, spindle, plasmacytoid, rhabdoid, or squamous according to the new WHO. Extremely pleomorphic nuclei, prominent nucleoli, nuclear pseudo-inclusion as mentioned, but also necrotic component and mitotic figures. And sometimes we might have, as in my case, a neutrophil in the cytoplasm having this abscess-like appearance. Osteoclast-like giant cells, which are, however, not neoplastic. Some other example, this is a spindle anaplastic carcinoma with also this coarse chromatin, and on the right, my cases with necrotic component. This is from the Bethesda, in which, of course, we underline that the squamous cell carcinoma now is a morphological subtype. Usually, they are positive for pankeratin, Pax8, and vimentin, focally or diffusely, negative for TTF1 and thyroglobulin, TP53, beta-catenin, RAS, and BRAF V600E mutation can be variably expressed, but mostly we have third promoter mutation in up to 75% of the cases. This is another example, 57-year-old female, 4 centimeters, single left thyroid lobe. No history reported. We have again this small cluster with some atypical nuclei, a binucleated cells, some sort of debris. Here you can see some sort of atypical cells with some prominent nucleoli in the middle of this highlight material, a sort of nuclear pseudo-inclusion here. I really didn't know what to do. So we performed the immunostains showing briefly negativity for everything. Thyroglobulin, TTF1 was negative also calcitonin. We performed also S100, which you can see here in the right bottom, was very vague, very unspecific in my interpretation of positivity. So we asked it for the clinical history, nobody mentioned anything, and we concluded as, of course, a malignant lesion, possibly not a primary thyroid lesion. Due to the fact that the patient had only this nodule, they decided to perform the total thyroidectomy. This is the the normal thyroid on the left in the bottom, and this is the lesion with this cohesive haphazard population of a typical, really atypical cells with increased mitotic figures and diffuse positivity for S100, melanoma, SOX10, BRAF, and negativity, of course, thyroglobulin, TTF1, calcitonin, keratin, and PAX8. So really, I don't know if maybe I needed to a better interpretation of this positivity, which for me was in that single cluster and partially a specific. This is for introducing a metastatic melanoma, moderately to mildly cellular smear, variable in size and shape, nuclear are usually eccentrically located, intranuclear cytoplasmic pseudoinclusions, and of course, intracytoplasmic pigment is not common. Positivity for the marker that we have seen. Another important metastatic lesion is, of course, renal cell carcinoma, in which we might have these large cohesive groups with the abundant evacuated cytoplasm, large nuclei, so low nuclear cytoplasm ratio, and prominent nucleoli. And this is an example of mine of the metastatic localization of the renal cell carcinoma inside a follicular adenoma. Positivity for CD10 and RCC, negativity for thyroglobulin and TTF1. Let's move briefly on the Mission Impossible. Tom Cruise, I'm eagerly waiting for the new movie for NIFT versus infiltrative follicular variant and in the encapsulated invasive follicular variant, but also the intrathyroid, parathyroid lesions, and follicular carcinoma and oncocytic carcinoma. NIFT was introduced by Professor Nikiforov and the panel of experienced endocrine pathology during the Boston USCAP 2015. Of course, they had the publication of the paper with the nomenclature revision for NIFT with major and minor criteria of JAMA oncology in 2016. But this led to changes in the implied risk of malignancy for the Bethesda categories in which these lesions are diagnosed, including AUS, follicular neoplasm, and suspicious for malignancy, as you can see, of course, here. Different authors, including my group, tried to identify this entity on cytology, but it was completely unsuccessful, as mentioned also in this paper by Professor Fackwin, in which, comparing a NIFT, the first 6 pictures with infiltrative follicular variant, they concluded that especially on cytology, it's impossible that they can be distinguished. This is an example of my case. I decided to sign out this as follicular neoplasty or 3B, although there were very slight and irregular nuclear pleomorphic features, very slight, and this was an FP on histology. So different authors try to think about the molecular profile, but it was unsuccessful. RAS mutation up to 60% of the cases, but they are also positive in follicular adenoma and follicular carcinoma. BRAF K6-100E in 10% of the cases, PAX8 PPR gamma in 30%, but they are especially seen in oncocytic carcinoma, fusion, and so on, including Dyson-1. BRAF V600E is usually wild type, always wild type, and gene sequencing classifier is suspicious. So this is an histological diagnosis, and we need to include the entire, of course, capsule for the infiltrative evaluation. The Bethesda reported the decrease in the risk of malignancy of the categories if excluding nodal diagnosis NIFT-P as percentage decrease and estimated final risk of malignancy. And they also analyzed some cases. This is an example of a follicular neoplasm with some clearing, with some nuclear grooves. In the comment, you can add among the differential diagnosis that you cannot exclude a NIFT-P. And another example in which we have a combination of cells, hyperchromatic, but also some cells are roundish with some cleaving, and this again was a NIFT-P on histology. Let's move on the crystal briefly ball to, as you are a witch or a wizard, for some other entities. This was a male with these 2.5 centimeter lesions, hypoechoic left thyroid. You can see we have some clusters, larger cluster or small microfollicular cluster of cells with this very granular vacuolized cytoplasm neoplasm, round nuclei, medium size, some very granular also chromatin. The only thing that you might recognize here is a sort of nuclear molding. We perform thyroglobulin, but we also perform PTH, which was positive. And this is for introducing the intrathyroid parathyroid lesions. It's impossible to identify them based on morphology alone. The only difference that we might recognize between parafollicular cells and follicular cells is that they can be a little bit smaller and with a little nuclear molding, but we need the support of immunostains for GATA3 and PTH. And the same for oncocytic parathyroid lesions, pretty identical. So we need only the support of immunostains showing positivity for PTH. This is an example of mine, LBC, oncocytic cells. We perform the immunostains, PTH positive, but on the right you can see another conventional slide of oncocytic cells. This was not a parathyroid lesion, but this was an oncocytic follicular neoplasm, but just for underlining the pretty identical evidence. Granular cell tumor, they are defined by this oncocytic granular appearance, which is pretty similar to the oncocytic cells. Again, if we are lucky enough to have a cell block, we can perform HAS100, which is positive, SOX10, and CD68. And last but not least, of course, darkness on the edge of town, oncocytic and follicular adenoma versus oncocytic and follicular carcinoma. Both of them are reported as follicular neoplasm or AUS according to the morphological criteria. It's an histological diagnosis. It's impossible to define capsular and vascular invasion on cytology. And also the molecular profile show many important overlapping between the benign and malignant counterpart. This is a recent case in which we have this on mine, in which I have this microfollicular pattern. Again, in front of this, we might have two different options, a follicular adenoma or a follicular carcinoma. In this case, this was also with vascular invasion. I don't know the result and the histology of this, so as soon as I have, I will let you know. So in conclusion, I don't know if we are in a fight club with the difficult lesions or we shall dance peacefully as Richard here in this movie. But we need to be prepared to have also to encounter something unusual and challenging in thyroid cytology. Usually these unusual cases are rare, so they can be misdiagnosed. The Bethesda, of course, describe the criteria for many uncommon entities. But generally speaking, if something looks unfamiliar and it is not able to match all the criteria for a standard and classic diagnosis, just stop, look at the case again, combine with the clinical history, or if you have the prior pathology material, in order to define correctly if you need ancillary technique and which one do you need for the conclusive diagnosis. And with this picture, School of Athens, Raffaello Sanzio, Vatican Museum, in which you can see a bench of philosophers all together, or if you prefer something else, this group of people by Caravaggio. Let's share our experience, your question about some difficult cases, which I'm sure you encounter as everyone in the daily practice. And really, thank you so much for being with us and for, of course, starting to follow this new series of webinars. Thank you so much.